I'm going to hand over to Sri, who's going to introduce the structure of the debate, and let's see what therapy we think is going to be right for BPH in 2017.
Good morning and welcome to the much-awaited balloon debate. The concept of balloon debate is really the best of British urology, and it is transported across the globe to many international meetings, and it's becoming a constant fixture across many parts of the world. We've got the hot air balloon here floating over the city of Glasgow. We have 6 protagonists arguing for the new concepts, devices, etc. of the surgical management of BPH. We understand that not all concepts are new. Some of the age-old concepts are also there to see how they compete with each other in terms of technique. After each round, the balloon gets heavier, and a participant will be eliminated so that the hot air balloon does not crash and it still is afloat. The debaters will use their knowledge, evidence, presentation skills, wit, sarcasm, etc. to impress you, the distinguished members of the audience, to keep them for more rounds. You will vote after every round with your smartphone app, which Jonathan just explained to you, and he will again explain at the end of this brief presentation. The first round will have 3 minutes and 1, 2, or 3 slides. The subsequent rounds will have 2-minute presentation with 1 slide only. So please vote after every round for the person you want to eject. I reiterate, you're going to vote for the person you're going to eject from these rounds. And the speaker who gets the most number of votes will be ejected from that particular round, he or his technique. If for any reason there is a tie, then the opinion of the chairman is final and binding on what happens. I have with me Jonathan Glass, who is an expert in this kind of balloon debate apps and the audiovisual functioning of it, because they do it in guys very often. And also we've got excellent audiovisual team. Hope everything goes well. So hand over to Jonathan.
So I think we ought to get going fairly quickly with the speakers. Get your apps on. Just the speakers, we warn you, we're a bit tight for time with the previous session overrunning. So on one round, we may end up voting 2 of you off in 1 round. But let's see how we go. We've got a deadline of 11 o'clock. Let's introduce the first speaker. I think it's Neil Barber.
Neil Barber is going to speak about green light. Slides for Neil Barber.
Good morning. Thanks very much, Sri, for the kind invitation to come and take part in this debate. I guess when you go to the AUA, everybody starts with their disclaimers, and I pretty much should disclaim on most of the technology you're about to hear about, except for PAE and HOLEP. My job is to try and sell you, or discuss with you why you should keep, in this round at least, green light laser vaporization of the prostate. It's been around a long time. I first came across it in sort of just after the millennium, actually. And I was asked to write a chapter about lasers in prostate surgery. And what it seemed to be was the first technology that would efficiently vaporize tissue to make the kind of hole we're all looking for through the prostate, but did it with what seemed to be unparalleled hemostasis. And this meant for the first time we had a procedure where you could make a large hole through the prostate, relieve the symptoms as we want to, but do it as a day case procedure. And when we introduced it to King's in 2003, it was in a day case unit and the doors shut at 7 p.m. Everybody went home with a catheter to come back and have it out again if they hadn't had it out before they left. It's gone through an evolution from a 60-watt laser to an 80-watt, which is what I came across, to a 120-watt and now a 180-watt laser, which is very efficient at removing tissue in a timely fashion, but with the same hemostatic properties. But it wasn't recommended by NICE in 2005 and 2010 in their male LETS guidelines. They said to offer monopolar or bipolar TURP, a HOLEP, incision of the prostate if less than 30 grams, or an open prostatectomy, and not to offer, amongst many other things, laser vaporization of the prostate outside of a randomized controlled trial. So that was the line that was drawn back then in terms of what should be seen as a recognized procedure that we should be offering our patients routinely. And that was despite having many hundreds of peer-reviewed publications relating to the laser. And indeed, by 2010, there were 2 single-institution randomized controlled trials versus TURP. As a response to that, we had to, those who are involved in green light laser, be involved in a large, multi-centered randomized trial called Goliath. And this was a prospective, randomized trial, multi-centered, multinational, to give us the highest quality data that we could to demonstrate the already, in many ways, proven efficacy of this procedure. So in 2017, I think that bar is set even higher. And we as urologists in Britain and BAUS and around the world should demand levels of evidence of this kind of type to certainly vote through a procedure to the next round of this debate, but generally in terms of what we should be offering our patients. You need it if you want to get approval by the FDA, if you're a new device. You need it for NICE if you're going to get approval in terms of what should be recommended treatment for patients in the UK. And you need it for the AU if you're going to get the level 1 evidence in terms of recommendation that you would want to back up the offering to the patient you're going to give. So I think in this round, it is your role, I believe, to be rejecting a procedure which has no evidence of this kind of level, does not have any recommendation through the EAU, and is not NICE accredited. And what's more, there are no real plans to start any study of that type or quality. And that is what you should be leaving. And the reason it's black and white, because I'm afraid to say that should be the radiological procedure. Thank you very much.
May I call upon Oliver Case for Eurolift?
Good morning. So, I first heard about Eurolift in 2011 when Tom McNicholas presented this at the RSM ski meeting. And I have to say, I was as skeptical as anybody has ever been in the room, and it was a real scoff at sort of the things that had gone before with microwaves and tuna. I said, this is never going to get off the ground. And then, you know, as the great William also said, you know, you've got to treat the patients in front of you. And I started thinking, well, somebody said this is reversible. I thought that's the first treatment I've heard of for BPH that's reversible, apart from taking pills. It causes no sexual dysfunction. It can be done under local anaesthetic. I thought this is going to have some interesting uses, and I've got a few patients I could use this in. And I think everybody starts thinking about that, and then the evidence came about. Now, if you've got evidence behind a treatment, then you've got some real power. Now, the BPH facts. This is what everybody's going to share, and I don't often agree with Neil, but you know we're on the same page here, Neil. And this is probably because you're a Eurolifter as well. Anybody else do Eurolift in the room? Freddie, you going to put your hand up? Do you do Eurolift? Interested? Tried it? Okay. Yeah, we got a growing population of men, and my iceberg here is really picking out the sort of 15% of symptomatic men that we would treat. These are the IPSSs of above 20. But look at the underneath. We've got 50% with moderate symptoms who are really still in the care of the community and trialing drugs, coming off drugs, and not considering the alternatives. And the staggering last 2 points is only 3% of people will go on to consider surgery because blasting a hole in your prostate is not the right thing to do. Being gentle with the tissues, which is what we're taught as all surgical techniques, is imperative. So if I've got a 60-gram prostate, high IPSS and a poor flow, what am I going to do? So I could go with Neil's laser, but I don't like the old stuff. Those trials saying that I'm going to have dysuria and actually I'm going to be worse off. I'm going to have terrible storage symptoms. I'm going to need a catheter. I'm going to pass debris. I could go for this new water jet acroablation. No evidence. Where's the availability? How much is this machine going to cost? You know, I think this is way off. TURP, it's old technology, it's reliable. Let's push this one through for a later round where we can compare the evidence against Eurolift. And HOLEP, again, you know, I think it's got a primary role because that's certainly a better option than doing an open prostatectomy. And prostatic artery embolization, you know, I think we should just piss in the breeze there. You know, there's no evidence, there's very few centers doing it, and it's done by radiologists. Let's keep it in the world of urology. So let's get rid of those first 2 rounds first. You want to do your dual vote off? Let's do that first so we can get down to the real meat and veg of this debate. So if the alternatives about Eurolift is, if I'm going to go onto medication, this is something that lies in between medicines and surgery, isn't it? We keep saying, well, we're going to compare it against surgery. It's not really comparing apples with apples. This is about saying to guys, do you want to take pills for the rest of your life which barely work and you hate the feeling of being on pills, you forget to take the pills and they give you side effects, particularly with your sex life? Or you're going to go and see a prostate surgeon who's going to core it out under general anaesthetic and you're going to be in hospital a few days and your recovery may take months. So we're looking for something that's going to de-obstruct people earlier and look for preserving their bladders in later life. Don't wait until the prostate's 300 grams and they have to have a HOLEP and their bladder function is negligible. Let's do it earlier in the cycle of BPH so they get the benefits into later life. And remember, do no harm. And that's what UroLift is all about. Thank you.
Thank you, Ali. Waterjet proponent, Andy Thomas.
Ladies and gentlemen of the voting audience, in political terms, 2007 has been the year of the underdog. First, we had Donald Trump in January becoming president of the USA. You can see if Donald had chosen a different career, he'd have been a pretty good urological surgeon, and that with a very aggressive DRE. And then in May, there was Emmanuel Macron, started a political party 14 months ago, is now president of France. And the near miss of Jeremy Corbyn in our general election only a few weeks ago. And in political terms, I'm the underdog for this BPH debate. Here I am in my conference gear on the right here in the AUA in Boston. And Boston in the back. And the water trial data was presented there last month, randomized control evidence to show this is a very effective technique. So, we don't yet have robot surgeons. Prostate cancer has Da Vinci robotic surgery, and we now have our first robot to treat BPH. And this is the robot on the far right. And this is a robot that delivers a high-velocity water jet to resect your prostate. The image is gained by ultrasound, so ultrasound skills are very important, horizontal and longitudinal imaging. And the plan is made on the console. Then there's a specialized handpiece that's inserted down the urethra, locked in place as a bit like doing a template biopsy. And this is 24 French. And there's a specially designed flexible cystoscope to view the procedure. So what the surgeon does, the surgeon sits back, enjoys himself, and just pushes that button there. And what's particularly good about this technique is that the average treatment time is between 4 and 6 minutes. So this is rapid surgery. And at the end of the procedure, you will pass a catheter, a bit like Foley described. You blow the balloon up in the prostatic fossa, not in the bladder, and apply some catheter traction. So I would say this is a win-win situation. It's a win for the surgeon, but this is very reproducible, very short learning curve, a win for the patient. In fact, you get TURP results with less dysuria, less respiratory rate ejaculation than TURP. And for hospitals, for the shorter procedure, you're going to get improved theatre utilization rates and shorter waiting lists. So keep me in, and I'll show you a video of the technique, which you may not have seen, and I'll present some data from the water trial. Thank you very much.
Thank you, Andy. Welcome, Rebecca Triguna, to talk about TURP. Has it still got a place?
Right, so my name's Rebecca Triguna, and my pitch is very simple. I'm Rebecca Triguna from the Conservative Party, and I think I'm the best person to stay in the balloon. TURP remains the gold standard for surgical treatment for BPH. Despite other newer technologies presented here today, these surgeons, along with most of you in the room, will continue to perform TURPs. My party will deliver on the wishes of the British urologist because I believe in TURP and that our best days lie ahead. Bipolar TURP is the future. We have the highest level of evidence comparing monopolar with bipolar TURP, which shows no significant difference in terms of functional outcomes, subjective or objective, but a significant improvement in terms of safety profile. At this moment of national significance, there should be unity here in Glasgow, but instead there is division. Whilst other newer technologies may have their raison d'etre, for example, green light laser may be better for men on anticoagulation, although that hasn't really been proven. UroLift may be better for men that are worried about retrograde ejaculation. PAE may be better, may be useful for men that can't undergo a general anaesthetic because they're elderly or unfit. And waterjet may even turn out to be a good, more minimally invasive procedure. And HOLEP, dare I say it, Mr. Banks, may even be superior to TURP for very large prostates. But we know that there was a slight exaggeration from the vote leave contingent And although Brexit does mean Brexit, we won't be investing quite enough money into the NHS to afford all of these techniques. So what we need is one procedure for the many, not just for the few. So please, ladies and gentlemen, do we want a coalition of chaos or a strong and stable TURP?
Thank you, Rebecca. Can we now call Mark Harris to say about embolization, to debate on that?
Well, I realised in starting that I'll be as popular as the lovely welcome I've had already from Ollie and from Neil, as the Lions facing Kieran Reid and his merry bunch of hacker friends, which they'll have again on Saturday. Hopefully things will go slightly better. Standing up as a urologist in front of the finest urologists in the country and beyond, trying to say that a radiologist should do the procedure. But as we've already heard, the radiologists are basically doing aquablation already, because if you've got ultrasound skills, well, the radiologist has that, they can do it and press the button, 4 minutes later they're done. So is that a surgical option we want? The other colleagues have very kindly already made my debate for me. Green light laser, not proven evidence. The evidence that is out there says that not to use in acute retention, not to use in over 100-gram prostates. The contention about whether bleeding really actually makes much difference or not makes it a bit difficult to sell. And Urolift, I don't know whether 35% they're above the iceberg and the 50% below. There's a 35% missing factor on the Urolift of those that definitely need treatment and those that have something. PAE offers that option for the unmet need. Now, I'm very grateful for Ollie's registrar to show me the picture on the bottom left. It wasn't a Urolift, I have to admit. It's one of his TRPs he was playing with, so it's probably best he sticks with his simple toys and just does a bit of stapling. The chap I met in an Austrian bar, I can't guarantee we're going to get everyone to pee like him or like the chap on the right, but we'll give it a go. But I wanted us to think, what actually makes a difference? There's all this unmet need out there, the option of medication, and we all know that basically we've been on that for far too long. It's not that effective, and people don't like it or don't get much benefit from it. And you've got what we all really like to do is basically invasive surgery of some sort, but there's that huge void in between. Men who want some benefit, but not too much, not to have invasive surgery, not to have GAs, not to be bleeding, and all of those boxes. How many of the other contenders can say they've got day case procedures, local anaesthetic, catheter-free? Everyone hates a catheter. I don't know how many in the group have had one, but I've not, and I don't ever want to, but we put them in all the time quite glibly. Minimal bleeding, minimal dysuria, no sexual dysfunction or retrograde ejaculation. You're not putting instruments and things down the urethra so you don't get strictures. Minimal complications, a bit of suprapubic pain, which usually suggests that they're actually getting a good result. Short procedure time between 60 and 120 minutes. Quick recovery, they're back to work within a few days. It's effective and durable, and there is evidence out there. There's an RCT coming out in September, which I can't unfortunately release the results of, surprise, surprise. And it's relatively affordable and preserves fertility. So if you actually want something that covers the majority of men that doesn't have an option at the moment, PAE is your man. And you still need a urologist to help support the radiologist to tell them what to do. Many thanks.
Thanks, Mark. Can I call upon Freddie Banks to talk about HOLAP?
Thank you very much for offering me the opportunity to speak. I would like to talk about HOLAP. Now, when we are doing prostate surgery, we have basically one goal, and that is to pee. And you can make no bounds about this. If you are going to pee properly, it is a simple radius issue. You have got to get that prostate open and wide. Providing you've got a bit of bladder pump pressure behind you, then you will pee. The problem is, or the other key thing is, that if you are going to have a durable operation, it is entirely proportional to the amount of tissue that you take away. If you take a lot away, nice clean resection, then you are going to have a long-lasting, totally durable procedure. The problem is that you have a multitude of indications for why patients are having prostate surgery. There are patients with urosepsis, they've got big residuals, small residuals, they've got stones, they've got big prostates, small prostates. You've got endless options. And there's only one technique that can actually deal with every single prostate scenario put in front of you. And the only one that can do that is HOLAP. This is what my patients tell me when they come and see me in the clinic. I'm peeing like a horse dog. And I can tell you, I don't think there's any other procedure offered tonight, or this morning rather, that can actually deliver on that. So I commend to you HOLAP.
Thank you. Thank you. The first round is done, and now is for the voting.
So get your apps on. We need a load of you to vote. So start voting. Are we going to have Mr. Barber's green light? Is it green light for green light? We're going to treat the 50% who want Eurolift? Are we going to vote for the underdog? Do we need Mr. Strugger's strong and stable TURP? Are we going to meet the unmet need for embolization? Or are we going to vote for Mr. Banks' durability? So get voting now. Remember, you're voting for the one you want off the balloon. I've just heard from air traffic control the balloon is sinking into the Clyde. So you need to start voting and vote one of the off the balloon.
One or two off.
I'm afraid I don't think we have a Brexit 50-50. I think, Mr. Harris, thank you very much for your contribution, but you're off the balloon. You're sinking into the Clyde. Right, I think we've concluded round one. So we now vote for the second round. We've only got 5 people left in the balloon. Let's call Mr. Barber to come back up.
Thank you. So in this one slide, I just wanted to confirm, really, and refute some of what we've heard earlier. There is excellent evidence about the efficacy of green light laser as a surgical treatment for BPH. This trial was unique in being multi-centered. That means lots of different surgeons performing the procedure and very experienced TURP surgeons as well in comparison. And this demonstrated and confirmed what it aimed to do, which is non-inferiority, i.e. equality of green light laser in achieving what we want to do. As Freddie was saying, we want to make people pee better, and we want to see their symptoms improve, and it demonstrated equivalence. It did so also demonstrate that there was a shorter catheterization time and a quicker discharge from hospital. But this isn't a new technology, as I alluded to earlier on. This has been around a long time. It's a mature technology. There are many hundreds of thousands of patients around the world who have had this operation done. It's the most popular surgery for BPH in France. It's the most commonly performed laser procedure for BPH in the US, and laser procedures outdo TURP in terms of numbers there. Don't let us fall behind the French, for goodness sake, in terms of technology. It is not experimental, and though I love aquablation in many ways, as people here know, it is very new. Barely 300 patients in the world have ever had it done. Stick with the one that's been treating thousands of people around the world. Please bring green light back to the next round. Thank you.
Eurolift and Ollie.
So unfortunately, I got the cameras on, but this is Guardians of the Galaxy. I'm actually Guardians of the Prostate, and we're saving the one prostate at a time with NeoTract. And NeoTracts are, they come into some criticism with the evidence is all industry-based, but they're a very ethical company. I think they should be actually applauded for how they're looking into minimally invasive treatments. So I'm going to go on to say, why does Eurolift make us all happy? And don't listen to Freddie Banks, who's the son of a very eminent Tory MP. He will U-turn, but I've finished this presentation. Don't worry about that. So we're all happy with Eurolift. Patients are happy, staff are happy, managers are happy. And why is that? Well, let's look at patients first. So this is a fast procedure. Andy said aquablation takes 4 minutes. It doesn't, Andy, does it? It takes about 40 minutes. It's just the treatment time's about 4. We take about 4 minutes. In, out, peeing in theatre, walking out. It's durable. There's a lot of nonsense about this not being a durable technique. I'll present that data in a later round. 100% day case. No catheters, no bleeding, no ejaculatory or new ED. No medications. Up to a third of patients will go back onto medications after TURP surgery based on a couple of very good evidence papers. And we can improve symptoms and we can improve quality of life. And is that not what we're trying to do for patients? They want to feel better. They might want to be like a horse, Freddie, just a human being. Are staff happy? The staff were the most amazing thing. We implemented this in Leeds in January, and we've been doing it privately before that. And the staff couldn't get over this. So we're saying, well, we're going to do all these TURP patients today. and the speed of the process and the lack of problems and the fact that the patients were awake and happy having this procedure done, it blew everybody away. And again, there's no mucking around. They don't have to put up 10 litres of irrigation. It's not going to be 3 hours. Anybody who does HoLEP surgery, there's always a groan. Oh, it's a 300-gram prostate. We're going to be here all morning. It's really, really fast. And they see the benefits, and they often don't see that. They don't see patients get up, have a wee, and go home. They see patients still asleep going around the corner with blood coming out of a catheter. And what do the managers say? Well, they like it. They like it because it's fast. It's a low retreatment rate, 2 to 3% a year. They like the fact we're using our ambulatory care units more, not blocking up inpatient beds. We have a £1,500 saving per case, and that's been presented in the session next door. We can move this to an outpatient procedure. It doesn't have to be done in a day unit. There's no investment costs. Now, I like HoLEP. I think it has its role in big prostates. Can I get it into my trust with $250,000 investment? No chance. But I have got Urolift in. I've reduced my waiting list, and I have fewer complaints because these patients are happy. Thank you.
Thank you, Ollie. Andy Thomas for the water jet.
Right, I have a video. So in my best American accent, I've done a quick video for you to try and, but I'm sure none of you have seen aquablation. So I'll be quiet while I just play this shortly.
The aquablation procedure is initiated with the placement of a transrectal ultrasound followed by transurethral insertion of the AquaBeam handpiece, which has an integrated cystoscope. Using truss imaging, the surgeon plans the angle of resection in the transverse plane and the treatment contour in the sagittal plane. Next, the AquaBeam system delivers a robotically controlled, high-velocity water jet for precise tissue resection according to the planned treatment. Once surgical planning is complete, we initiate the aquablation treatment using a foot pedal. During aquablation, a high-velocity water jet is delivered at various flow rates based on the required depth of penetration, which enables a controlled resection of the prostate according to our prescribed treatment plan. Bipolar and monopolar cautery can be used post-aquablation. Alternatively, hemostasis can also be achieved by positioning the balloon of a Foley catheter inside the prostatic cavity to tamponade the bleeding.
So, I'm pleased to report we do have some randomized control evidence. So that there's been a very good study called the WATER study, which has been, it's a multi-center, double-blind study performed in New Zealand, Australia, UK, and the USA, non-inferiority study, for men between 40 and 80 years of age, up to 80-gram prostates, 2-to-1 randomization, 3 years follow-up. We have some 6 months efficacy data and 3 months safety data. At 6 months, aquablation is non-inferior to TURP, and in terms of safety, is actually superior to TURP at 3 months, especially in regards to retrograde ejaculation, which occurs in 6% versus 24% with TURP. So this is a new procedure, but we have some level 1 evidence, be it early, to kind of to demonstrate that this is a very effective technique. I'm 10 stones 12. I'm sure if I stayed in the balloon, it'll stay up. Thank you very much.
Thank you. Rebecca again to speak about TURP.
So I'm not actually going to speak about TURP. I'm going to attack other people's policies because I'm like any good politician. Moving through that. Right, so let's speak about waterjet. So a lot of evidence from waterjet comes from Peter Gilling's group in New Zealand. And it's essentially a robotic dental flosser, isn't it, really? Now, although they initially used laser to cauterize bleeding vessels, they found that was ineffective. And so what have they come back to? Good old-fashioned TURP equipment, the roller ball and the loop. So any argument about water, about there not being any thermal damage to surrounding tissue surely is negated by that fact. Resection time is short. We said, 4 to 6 minutes, but the actual procedure takes as long as a TURP and involves a general anaesthetic, so hardly minimally invasive. Much like Boris's water cannons, I think water jet is an ineffective solution that's surely going to end up on the scrap heap. Vote Conservative.
Thank you. All at Freddie Banks.
Let's just see where we go. Right, I'm not the most organised person, so I suddenly thought, oh my God, I better take some pictures of prostates. So I've got last week's prostates. So, Ollie, here we are at the BAUS conference. What does BAUS stand for? The British Association of Urological Surgeons. It's not the British Association of Prostate Ticklers, is it? And, you know, that is basically your technique. So here we have the classic, this is a 50-year-old patient who comes to me with a terrible flow and, hey presto, whopping great median lobe. Can you deal with it? Of course you can't. What do? Send it to Freddie Banks. You know? So I have turned down one patient in 9 years for HOLEP, and that was a patient who had such bad ankylosing spondylitis that he was completely seized and just sort of rocked, and I couldn't physically get into his perineum. So that is the only patient in 9 years that I've not been able to operate on. This is a typical patient that simply can't be operated on by Urolift. It's tickling the prostate, and you should forget it. Do a proper operation, learn to be a proper surgeon.
Thank you. Two closes and
So, get your apps open again. I think Neil Barber is saying, do we want to be better than the French? I think Mr. Case is saying, do we want to make everyone happy? Do you believe the video? Do you believe Ms. Tregonner's cynical politics rubbishing the other sides? Or do you think we need to attack the median lobe? Vote now. I think, again, another convincing vote. Thank you very much, Mr. Thomas, for your contribution, but you're taking a dive. We're down to 4. The balloon is still just about floating with the third round.
third round, and Megan call upon Neil Barber to defend green light.
Here we are with 3 procedures that make large holes through the prostate and the one that doesn't. And we're all urologists in the room, probably. And fundamentally, in our DNA, we know that if we want to do the best for our patients, it's about making the biggest hole you can, as safely as you can, through the prostate to achieve the outcome you want. And that's what we want to do. And you want to do it with a procedure which is safe, and that means that having finished your operating list, you can go and have a refreshing beer afterwards, which we all like to do as well. Thank you very much.
Thank you, Neil. Ollie, Eurolift.
Okay, it's getting dirty now. I'm not picking on Freddie, I'm going to pick on Rebecca. So Rebecca's just told me she's ST6 and hasn't met her indicative numbers for TURPs yet, so... So I'm going to move on to TURP versus Urolift, because we measure everything against TURP, because it is an old measure. But why are we still using this funny little electric wire loop to make, 1,000 cuts into the prostate to try and achieve, only a moderate improvement in the symptoms and the actual flow of the patient? So it's a rather big hammer to hit the same nail in my boat. What we want is something that gets patients back on their feet, back into work, back into normal life as quickly as possible. And Urolift does that because you haven't got a catheter, you haven't got bleeding, you go home the same day, and you haven't got the aftereffects of anesthesia in many cases. That's not the same for TURP. The sexual dysfunction aside, most patients, if they're younger, want to maintain their sexual function. You've got to take that into account when you counsel patients. And it's about bespoke surgery for patients now. Yes, middle lobes are important for Eddie, and the MedLift study will give us some more information about how to treat middle lobes with Urolift. But you've also got to counsel them about making big holes in their prostates and the fact they won't ejaculate again, and you're going to ruin their fertility. And this is the BPH 6 study. This is the 12-month. There's a 12 months in the 2-year data. And in essence, if you have a TURP or a Urolift, you feel as good either way. Fine, the flow's not going to be as good, but then again, we are putting the treatment at the range that the patients need, not doing what the surgeon thinks that they want. And if we can do 10 Urolifts in a day, how many TURPs is Rebecca going to get through? Maybe one, I think. Okay.
Thank you. Rebecca again.
Can we go straight to slide number 7, please? No, don't go through it. Don't go through it. No. Slide 7. Yeah, go back. Oh my gosh, shall I come over? They are, aren't they? Okay, well, look, I'll start because we've not got much time. So a meta-analysis of transurethral procedures, all transurethral procedures, demonstrated that green light laser actually had the highest number of perioperative and late complications. The Goliath study, which was mentioned earlier, of 281 patients compared the TURP with the 180 watt, the latest laser that's out there. But it's only ever designed to give 2 years of follow-up, so hardly long-term results. Much of the argument for green light laser rests on the reduction in blood loss, but we should note that in the TURP arm, it compared both monopolar and bipolar TURP, and we know that bipolar TURP results in much less risk of blood transfusion, so hardly a fair analysis. And in fact, actually only one patient required a blood transfusion overall. And additionally, more patients had overactive bladder, at least in the short term, following green light laser rather than with TURP. So much like green light much like green energy, I'm afraid that green light laser really isn't an all-encompassing solution able to replace TURP and is certainly not appropriate anywhere. Vote conservative.
Thank you, Rebecca. Freddie for the whole lab.
Right, well, I'm just going to come back to yet more applications of why we need surgery. So, yet another typical scenario of a patient. Nice dinky little prostate on this one, but some rather large stones, nice elderly patient. Now, how is Neil going to deal with this? Hardly going to get your green light out and tickle those, are you? You know, I was hoping that Andy was going to be in so he could pressure wash them for me, polish them up like some nice marbles, you know, make them look nice. But, you know, you have to have a technique that you can deal with things. Whatever comes at you, you just get on with it. Takes a bit of time, okay, but you break up all the stones, wash them all out, deal with the prostate at the same time. Grateful patient, peeing like a horse. That's what we want. Stop mucking around with tickling technologies and do proper operations. Thank you.
So I think Mr. Barber's saying that urology is all about the golf club and the pub. Is that what we're voting for? Do we want the bespoke surgery of Urolift? Some evidence in this round from the TURP party, or are we about the universal applicability of the HOLEP? Vote again. It looks like that Urolift is going to have to start making a fight to stay in for the next round. But this round, Mr. Barber, I think, is fleeing the balloon. We've got 3 left.
Thank you. The next round, Ollie for the Urolift.
Okay. So, what do we got? We got left in, we got HOLEP, we got TURP. We've ejected the untried, untested, and the useless. So, what would I have? Well, I'd have a Urolift, naturally. Not because that's what I'm got the more experience in now, but because of the fact that I'm going to have a low retreatment rate. I'm going to be able to preserve my bladder function at an earlier stage. I'm going to engage with my urologist over the next 10, 20 years, looking after my prostate from all angles, not just prostate cancer, but BPH and low urinary tract dysfunction. I'm not going to ever wear an incontinence pad, thank you very much. I'm never going to have a urethral stricture and have my mouth stripped out to have a BMG. And I'm going to live my life as a normal bloke, thank you very much. Whereas Freddie's going to do unmentionable things to me, which he did 20 years ago on a rugby tour, but we won't talk about that. And I'm going to be happy for as long as this data keeps coming out and telling me that it's a durable response. Nothing changes. Everybody thought this was a flash in the pan. I can promise you the 5-year data doesn't show any wavering lines. You're as good as the day you walk out as you are 5 years later on. And now we're getting the publications coming through. In the last 2 years, decent, high-level evidence, randomized controlled trials, meta-analyses is showing that this is as good as TURP, but with considerable other benefits. Thank you.
Thank you, Ollie. Rebecca for the 4th round.
How my slides do now. A bit short, aren't I? Right, perfect. Okay, so Urolift talk a lot about ejaculation, but they don't have a serious plan for action. This RCT of 80 patients compared Urolift with TURP. It was only ever performed on small prostates, and there was inherent bias in the trial because 22 of patients who were randomized to TURP actually declined the procedure and weren't analyzed according to intention to treat analysis. All subjective and objective voiding parameters were superior at all time points with TURP over Urolift, and erectile function was preserved in both arms. Now, although ejaculatory function was indeed superior for Urolift, men really weren't bothered about it. So you can see why these guys would choose to have a TURP over a Urolift, because at least they won't get caught.
Thank you. Freddie, thanks for the whole app.
This is a bit tricky, this. I didn't really expect Ollie to be anywhere close to in the balloon at this stage. Let's just come back to... Oh, hang on. Okay, this is another case from last week. Nice, dinky little prostate for you, Ollie. I thought this might be just right for you. But the reality is that this patient has got a post-void residual of 400 mils, recurrent episodes of urosepsis. Are you seriously, with your Urolift, well, how much is the increased flow by? 3.5 mils a second? The guy's hardly going to notice if you've done a Urolift on him. This is a perfect prostate for Urolift, but totally useless in this scenario. I keep on coming back. You've got to be able to offer patients proper operations to get them peeing properly. They want to pee with a strong flow, all scenarios. And you simply are never, ever going to get anywhere by tickling this with a Whitehall staple, lifting the lobes apart a little bit. They're not going to pee properly, and that's what we should be trying to do.
Thank you.
So I think we're now down to Urolift, which we're being told is going to require lifelong follow-up in the outpatient clinic. Maybe that's the incentive. Is it only for small prostates? Do we still stick to the TURP, or are you still going with Mr. Banks's complete applicability even for the infected patient in retention? We're entering the final furlong with a head-to-head race, TURP versus HOLEP. Mr. Case, thank you very much for your fantastic contribution. We're down to the last two. It's neck and neck. We're in the final furlong. The whips are out. Let's see who goes next.
One last time, Rebecca Dragoon.
Oh, they're my slides. Okay, so in a single centre from the US, looking at more than 1,000 HOLEPs that they performed, they found that in the long term, nearly 5% of patients had significant stress urinary incontinence. A meta-analysis published in 2014, which compared TURP with HOLEP, demonstrated no significant difference in terms of IPSS score at 3 and 6 months, no significant difference in Qmax at 6 months, and no significant difference in quality of life overall. Transfusion was one parameter that did favour HOLEP, but again, going back to what I was saying earlier, this was predominantly comparing monopolar TURP, and we know bipolar TURP results in less risk of blood transfusion, blood loss. Now, I'm sure Mr. Banks will present some data, although I've just seen a photograph of me on his next slide. So we'll be presenting data to say at other time points during follow-up there was a favourability towards HOLEP in terms of IPSS score, Qmax and post-void residual. But once trial sequential analysis adjustment was performed, allowing for sparse data, that was not evident at all. There wasn't enough data to say that it did favour HOLEP. So I think it's important, Mr. Banks, to get your facts and figures straight, because we don't want to be looking foolish. Vote conservative.
Thank you. Freddie Banks.
Right. Well, I think the beauty about HOLEP is it is such a complete operation. You start off the operation, you get on, you deal with it, you have a nicely shelled out cavity. And if you look at the randomized trial from Gilling and Fraundorfer, there was no redo surgery in the 7 years that they'd followed up, as opposed to nearly 20% in the TUR arm. The problem with TUR, of course, is you get the registrar factor. You know, typical registrar out enjoying herself, then starts to get a little bit more carried away, gets even more carried away, and then the next thing you know, they're turning up to work, and then they obviously don't know what's on the list, but they do want to do the operation. And they get a bit of a juicy prostate, and the whole thing just becomes a little bit of a hack. And then it all gets a bit bloody, and then they hand over the red mist. And instead of actually being a completion operation, the TURP just becomes a sort of a mild panic trying to stop the bleeding, and an exit just to try and get out and keep the patient alive. And a few months later, when you do a CT, this is what the prostate looks like. What you really want to do is to have a technique that can take a whopping great juicy prostate, shed it out just under an hour, and a few months later you've got a beautifully shelled out cavity, stress no leakage, peeing brilliantly. That is a technique that you should all learn and should be available to all patients. Thank you.
Thank you.
So, on behalf of the section of endourology, I want to thank all 6 speakers for a fantastic debate. The question at the end, I suppose we're asking, in 2017, does TURP still have it over all its competitors? We're voting for our final time. Is it Ms. Tregoner's TURP, or are we going with HOLEP? Oh, is TURP and HOLEP the new Brexit? It's 51%, 49%, just in favour of... It couldn't be closer. Well done, both. I think we give that a 50-50. Oh, no, actually, I think we call that an overwhelming majority in favour of HOLEP. Thank you very much to all the speakers on behalf of the section of endourology. A fantastic debate. We started late. We're handing over on time. Straight into the next session.
Thank you, everyone.